Health Variations 3 case study by Elizabeth Allen. The case study I have chosen is Jackson Smith, an 18-year-old male admitted to the emergency department with severe breathlessness. Jackson has a history of asthma. His airway, severe dysponea, inability to speak full sentences, and a wheeze. His breathing is at 32 breaths per minute, diminished breath sounds, and X-ray shows clear and hyperinflated lung fields. His circulation, his heart rate is 130 beats per minute. He has no disability, no exposure, no fluids, and no glucose. Asthma. Asthma is a chronic inflammation of the airways, manifested by difficulty in breathing caused by the narrowing of the airways. Asthma is categorized by frequent incidences of uncontrollable dyspnea, wheezing on expiration, coughing, and persistent mucoid bronchial secretions. The pathophysiology of asthma. The inner wall of the bronchial tube consists of a mucus layer surrounded by smooth muscle layers from inward to outward. In the asthmatic condition, the innermost mucus layer swell up and the surrounding smooth muscle layers constrict, causing the narrowing of the bronchial space and bronchial spasm. Dyspnea. Dyspnea is shortness of breath or difficulty breathing. Breathing may be shallow, strenuous, or painful. You may feel breathless or have a feeling of not getting enough air. Dyspnea is often a symptom of a disease or illness. Dyspnea results where there is an imbalance in the perceived need to breathe and the perceived ability to breathe. Oxygen builds up and oxygen deprivation is critical factors that result in dyspnea. The pathophysiology. Dyspnea results when an inconsistency occurs in the central nervous system between the afferent and the efferent signaling. As the brain receives afferent ventilation information, it is able to compare it to the current level of respiration by the efferent signals. If the level of respiration is inappropriate for the body's status, then dyspnea can occur. The three main components contribute to dyspnea: afferent signals, efferent signals, and central information processing. The central processing in the brain compares the afferent and efferent signals, and dyspnea results when a mismatch occurs between the two, such as the need for ventilation, afferent signals, is not being met by the physical breathing, which is the efferent signaling. The afferent receptors allow the brain to assess whether the afferent or motor commands to the ventilatory muscles are effective, meeting the required demands of airway pressure, airflow, and/or lung movement. Breathlessness reflects the relationship of the drive to breathe and how well our respiratory system is able to accommodate this drive. So when a healthy individual exercises, they have an increase in the desire to breathe and an appropriate response from the respiratory system as to how much volume we breathe and how quickly we breathe. In a patient such as Jackson having a severe asthma attack, he has an accelerated drive to breathe going from the brain to the respiratory muscles, but because of the bronchial restriction in his lungs and airways, he can't essentially do the work to match it. Oxygen therapy. Monitoring and documentation of delivery and flow of oxygen is a vital requirement for a target oxygen to be achieved. Hypoxemia is a risk factor for poor clinical outcomes. Vital signs, respiratory rate are also predicators of potentially serious clinical outcomes. Hyperinflated lungs can have adverse consequences on respiration. The positive pressure following expiration acts as an inspiratory onset load and requires the patient to generate additional negative pressure to facilitate movement of air and gas exchange. The additional workload due to chest wall expansion ensures breathing takes place at the upper respiratory system of the lung. The work of breathing continues to increase inefficiently, which may eventually result in muscle fatigue and, in more severe cases, ventilatory failure. Asthma assessment. Following the Australia Asthma Handbook, Jackson would definitely fall into the severe asthma category. Managing acute asthma in adults. Following the Australian Asthma Handbook, starting oxygen, as highlighted in purple, is an immediate response to Jackson's severe asthma, targeting oxygen saturations of 92 to 95%. Oxygen therapy. The treatment for asthmatic adults advises that a Hudson mask is necessary. The placement of the mask over the face increases the size of the oxygen reserve. The oxygen flow should run at a minimal rate of 4 litres a minute or more to prevent rebreathing of exhaled gases. Saturations should improve and be monitored, decrease work of breathing and increase oxygen saturations. Conclusion. Oxygen administration is a key treatment in respiratory care. The purpose is to increase oxygen saturation in tissues where the saturation levels are too low due to Jackson's severe asthma attack. The goal is to prevent hypoxia by maintaining arterial oxygen saturations. Thank you.